Hello, ladies and gentlemen. This afternoon, we are talking about diabetic ketoacidosis and hyperosmolar hyperglycemic state, otherwise known as DKA and HHS. And when we are talking about clinical manifestations, on page 1039, there is a safety alert, and on page 1039, there is also a figure 44.7. You will know both of those items. So when we are talking about the diagnosis of DKA is based on several factors. Blood glucose level greater than 250. This will happen rarely in a person that they may develop DKA at glucose levels lower than 250. And I know that we have seen many patients where their glucose level is above 250 and we just need to lower the sugar. They are not in DKA, but this is one of the diagnostic criteria. Ketonuria, which is ketones in the urine, an arterial pH of less than or equal to 7.3, sodium bicarb less than or equal to 18, and then a positive anion gap. So the treatment of diabetic ketoacidosis, the treatment of DKA, treatment priorities will include fluid replacement with isotonic normal saline. So the first thing we're going to do, or the first thing we can expect doctor to do, is to order that normal saline. Next, we are going to correct those electrolyte imbalances, focusing on and monitoring correction of decreased or increased potassium level, because please remember that DKA is based on monitoring and maintaining this potassium level. And this is necessary, so we are going to correct this potassium level before we are going to administer any insulin. So insulin administration, if we do give it, will be given by intravenous delivery. So your patient may very well be on an insulin drip. Fluid replacement with isotonic normal saline is essential to reverse the dehydration that has resulted from the osmotic diuresis. So monitoring and correcting electrolyte imbalance is essential to avoid the dysrhythmias or those neurological complications that occur with potassium and then sodium imbalances. I know that we're also mentioning sodium imbalances, but the potassium imbalance is the priority. And then insulin administration may be necessary to correct the hyperglycemia. And then prevention of diabetic ketoacidosis. We are going to tell the patient, educate the patient on how to monitor their glucose level and to be aware of when that glucose level is rising. And then patient education on the signs and symptoms of DKA, which will resemble that of a diabetic patient. They're going to be thirsty, they're going to be hungry, they're going to be in the bathroom a lot. Insulin instruction on how to cover those glucose elevations. Your patient may go home on a sliding scale and they need to know how to utilize that. Also, following sick day rules, box 44.2 is going to address sick day rules. You're going to want to take a look at that. Initially, hyperkalemia may be present because of the movement of positively charged potassium ions out of the cell. To maintain homeostasis, the body is going to try and fix things on its own. So, as positively charged hydrogen ions move into the cell, potassium will accumulate in the extracellular fluid. And so hypokalemia is then the possibility because of the loss of extracellular potassium in the urine because of the osmotic diuresis. So when we were talking about hyperosmolar hyperglycemic state, there is a table 44.7, DKA versus HHS. You will look at that table, you will know that table.